It's my pleasure to introduce our next two speakers who are experts in the area of macular degeneration. They're both very accomplished retina physicians with international experience in the diagnosis and the treatment, current treatments and future treatments, and promising opportunities for early diagnosis in macular degeneration. So I don't know which speaker is going to be first, Dr. Lujan. So let me tell you about Dr. Brandon Lujan, who will be the first of the two retina doctors. Dr. Lujan is an assistant professor of ophthalmology at OHSU at the KCI Institute. He specializes in diseases of the retina and the vitreous, and he is also medical director of the KC Reading Center, where he oversees the latest imaging technologies where pictures are taken inside the eye to help diagnose and guide the management of eye disease. I will introduce Dr. Flaxel now so that there can be a smooth transition between the two of them. Dr. Flaxel is a professor of ophthalmology at the KCI Institute. She's also director of the Macular Degeneration Center, and she is full-time practice in retina, but also is a participant in multiple clinical research trials and is a principal investigator of several studies that are going on now at the KCI Institute for experimental therapies for age-related macular degeneration and also for diabetic retinopathy. So first we'll begin with Dr. Brandon Lujan.
Good morning, everyone. I really enjoyed that talk. Becky, thank you so much. At one point you said that you've lost your vision, but I think that's not true. I think you've lost a lot of sight, but you clearly have your vision. And thank you for sharing that with us. So again, I'm Brandon Lujan. I'm really happy to speak with you all today and kind of give an overview of how we use imaging to understand macular degeneration and how we think about the process of age-related macular degeneration in the clinic, and try to make it clear what we're looking for in clinic visits and how this disease is seen by us both now and into the near future. I want to, again, welcome everyone on behalf of not just myself and Dr. Flaxel, but the entire KCI Institute retina faculty that's shown here. We all work together as a team to take care of patients, and it's a privilege to be able to do that. The best way to start, and the thing that makes sense to me, is anatomy. And to think about the eye as being like a camera. Now, the eye has about 240 million years or more an advantage over the camera, but as an imaging system, it's somewhat similar. Light enters in through the pupil and then gets focused by the cornea and the lens onto the retina, which is the lining on the inside of the eye and is analogous to the film in a camera. And it's nice to be in a room where most people know what film is. So everything that you see on this image in orange is the retina. You can see the optic nerve that's just next to where light is being focused, that's bringing an image back to the brain. And if we look at this two-dimensionally, or as if we were the light that was entering through the pupil onto the eye, this is what we see. So this is now what we see when we're examining the eye. And you can see the optic nerve that's normal in appearance here, and the retinal blood vessels that are also normal in appearance. And it's this center part here that is the macula. So the macula is that part of the retina that encompasses the most useful part for vision. And to give a rough size for those that don't know, it's about the width if you held your hands out in front of you and your two hands together. What you can see in that area is the macula. And it's that part that's obviously critical to function and to vision that's damaged in age-related macular degeneration. The good news about that condition is that's usually the extent of what it affects. Outside of that is usually spared. Within the macula, there's even a further area of specialization that's called the fovea, and that's right in the center, and that's what's useful for your best vision and for reading. So that's really right in the very center. So this is just a color photograph of very high quality that we see, but the test that we actually use the most, and what I'd like to spend a lot of time showing you and just educating you on how we use it, actually takes an image right through the center of the fovea, not as if you were light going through, but actually in a cross-section. And that technology is called optical coherence tomography, which is a mouthful, so you can just call it OCT. And just remember it as the first three letters of the month that we're in, OCT. And so this is an incredibly powerful technology and is really analogous to what's happening in sonar on submarines. So in submarines and sonar, sound waves are being bounced off different objects. In OCT, we use light. So a very dim infrared light bounces off of the retina and is able to give an incredible structure like this normal retina that you see here. So instead of looking at it, again, as light was seeing it, you're now looking at it in cross-section. So it's as if a slice is being taken out of that retina. And right in the center of what you see on the top, that dip is normal. That's the fovea. That's where the best vision is. And the idea being that all of the processing parts of the retina are kind of getting out of the way because the vision cells are actually all the way in the back. So it's that very back layer that has the vision cells and gives you your best vision. And that's important as we start to look to what changes we see in age-related macular degeneration. So here's an example of an eye that has dry AMD. So what you can see in this is that there are little yellow deposits or bumps that are called drusen. This is the hallmark of AMD. There's also some changes to the pigmentation. You can see that there's some areas that are a little bit darker there in the center. These drusen are not flat, and in fact, if we do an OCT through those drusen, you can see that there are actually large bumps that are under the retina. So those bumps are right down adjacent to the vision cells and are kind of the primary manifestation of AMD. So everyone with AMD at any point will have drusen. Everyone starts dry. We looked at just a cross-section, but it's important to recognize that OCT gives us a lot more information. We can actually calculate the volumes of those drusen, the thickness of the drusen, a lot of features to those drusen that help us understand where a patient is, and in the large clinical trials that I'm involved in the reading center, help us figure out who's doing well in clinical trials. So there's a lot of information we get just from that technology. The more advanced form of dry AMD that doesn't necessarily happen, but is the end result of dry AMD, is what's called atrophy, sometimes called geographic atrophy, because the area that's involved looks like a state. So here's an example of atrophy, and if we do an OCT through that, we can see that the area in the back where those vision cells are that I told you about in the normal eye are now missing. So what's happened is that tissue has not been able to survive this process of drusen, and as those drusen have broken down, the vision cells have gone with it. And you, in fact, see more light getting through to the deeper structures because the pigment and those vision cells are no longer present. And so this is exactly what your physicians are looking for on the exam to see if you're progressing to a more advanced stage of the dry macular degeneration. Of course, then there's wet macular degeneration. Here's an example of a patient who notices an acute change in vision. They've all of a sudden woken up with a blind spot, and you can see just on examination that there's blood there in the retina. And if you do an OCT through that, you can see the change that's occurrent to help understand what's happened here. There's blood in that center area, that's the bump, and there's also this dark fluid that's underneath the retina. And this is exactly what we're trying to treat with the injections and treatments that patients get in our clinics. So here's a way to think about macular degeneration that may be a little different than what you think of it as. When I first heard about it, I thought of it as kind of two separate problems. But going from the normal to dry macular degeneration, you start to have these bumps or drusen. Now, the natural tendency may be just to stay at dry, and patients can be just with drusen and have dry for the majority of their lives. The good news is this is a very slow-moving problem. But the progression of this over time is the continuation of dry into atrophy. And it's this atrophy that is responsible for 10% of severe vision loss in all of patients that have macular degeneration. So just going down this pathway of drusen that are then kind of breaking down and becoming atrophic or having atrophy can give vision loss. Now, a departure from that pathway, and here's what's different, is going off into wet from the drusen. So what's happened here is that blood vessels are now growing underneath the retina that cause that bleeding. And so this is a departure from that natural progression. And when we're treating that, we're actually not really treating the entire disease going back to normal. We're treating back to this pathway of dry. So it's a departure, and by giving shots, we're returning to this dry pathway. So being back on that pathway means it's still possible to have vision change and vision loss that is not something that we can treat with the shots. But if we see fluid on the OCT in clinic, or if we see hemorrhage on exam, we know that that's what we need to treat. And ultimately, it's that wet macular degeneration that's responsible for 90% of severe vision loss in this condition. So here's an example of a new application of OCT. This is a patient that comes in, and you can see there's a small, it's hard to see, but just directly down from the middle, there's a small spot of bleeding that's present there. The typical testing that we would do and the gold standard testing that we do in clinic is what's called a fluorescein angiogram. We're giving an injection of dye of fluorescein in a blood vessel in the arm, and then we're taking photographs as that circulates through the body. This fluorescein is, it's food coloring, essentially. It's what's used to color the Chicago River green for St. Patty's Day. but it gives us contrast, and it lets us see the blood vessels that we couldn't see just with examination. And it gets very bright in the center in the later phases of this study because of that fluid that we saw in the OCT. Those blood vessels that are there are leaking quite a bit, so it gets very bright and you can see that. If you're looking very early on, immediately after the injection of that dye, you can actually make out the blood vessels in their earliest form right in the center. You kind of see this tree, and that's actually the blood vessels that are under the retina in the wet macular degeneration. But it turns out that research at KCI Institute and around the world have developed a new application of OCT where you can take multiple images very quickly, process them, and actually determine the parts of that image that are moving and realize that those are blood vessels. So this is a new technique that's called OCT angiography. And the idea is that you don't need an injection, you don't need dye, and it can very quickly get information back to the physician about blood vessels that are present underneath the retina. And there's, in addition to the technological developments that are occurring at Casey, there's multiple research programs that are NIH sponsored and are in clinical trials. And this is an area that we're very excited about because it gives us much more information about wet macular degeneration and spares patients, importantly, from getting these shots and reveals a similar amount of information. It's not exactly the same, but it's moving forward at such a pace that its value is unquestionable. An example of that is from Steve Bailey, one of my partners in the department, who's looked at the size of blood vessels early on and has looked to see exactly what happens to those blood vessels and sees them get smaller with giving the injections. So this is something that will continue to be important and is something that we're following in clinic. So currently, for wet macular degeneration, we're doing these injections that are targeting fluid. We're trying to get rid of that fluid that's underneath the retina and cause those blood vessels to shrink down. And we're able to do very advanced imaging. What I've shown you, the cross-sectional data, this three-dimensional data that I'm showing you in the upper right that gives you a thickness, that's exactly what we're treating with the injections, and it's what we're able to measure very carefully. In the future, we're going to have more information. There's a lot of excitement around this term big data. What that means is that, especially in imaging, that we're going to have so much data about how eyes are early and how they are after treatment that when a new patient comes in, we can try to fit their eye and where they are in this disease process to an existing model. And the goal is to be able to better understand what's the optimal treatment regimen to improve their vision. So I do see that clearly as something that's going to change over time and is very exciting. This is not just the frequency of injections, but which medications, and there's a lot of information that still we have yet to learn that's going to help improve vision. We're definitely going to have better medications, and Dr. Flaxel is going to talk about some of the clinical trials that are ongoing. There's a lot of excitement. Gene therapy is something that is certainly going to happen to various degrees. It's already being applied in retinal degenerations. We're involved in a number of those studies at the Casey Reading Center and at KCI Institute overall. This will be applied to macular degeneration in the future. And there are also surgical implants or ways that medication can be put in the eye so that we're not having to do injections every month. And you'll hear more about that as well. And importantly, especially for me, is just better imaging. We're really at the beginning of what we can do, not just optically, but software-wise, to better be able to understand what we can see in macular degeneration. In terms of normalize, or patients that don't have macular degeneration, or relatives, siblings, kids of those that do, there's a higher risk of developing macular degeneration. So what's important, and no real surprise here, but wearing sunglasses outside, limiting the amount of UV light that's getting to your eye is important. Eating green leafy vegetables. You heard it here first. This is good. Exercise, not necessarily a marathon, but exercise, getting the heart rate up is critical. And then not smoking. Don't smoke, don't start, for all of those of you here. This is the biggest modification you can make in your lifestyle to keep your retinas healthy. In the future, I think we will have earlier detection with imaging. So we'll be more aware of people and patients who are going on to the early stages of AMD. For those that have dry, we're currently recommending the AREDS vitamins. There's 2 different types, and that's a discussion with your clinician about which is best to use. But clearly an Amsler grid is something that is useful in those that have dry that's of concern. This is an Amsler grid. I know this is familiar to many of you. The idea being this is a way to monitor your vision. You can imagine those bumps under the retina might cause some distortion, but if fluid came into the retina, you may change from a grid appearance to something where there's an area missing. So in the absence of being able to do our types of imaging every day, this is something you can do at home to be aware of any change. In the future, there will be better imaging. I think it's not impossible or unrealistic to think that the iPhones that we carry around are going to have an ability to monitor you better than an Amsler grid. There will be a better assessment of genetic risk, so both in terms of who's going to get it and who's going to develop quicker, who's going to respond to therapies, and what kinds of therapies you should be on. And then there may actually be pharmaceutical drugs that are targeting the drusen or targeting things early. That's really a goal that's still out there, but there's a number of clinical trials that are ongoing that are smaller at this point to try to nip this problem in the bud. And then finally, in thinking about the advanced form of dry in terms of atrophy, currently we still are recommending the vitamins. These are still preventing progression to a more serious form. And then there are a number of clinical trials that are ongoing or have completed. And again, Dr. Flaxel will speak to that. In the future, again, better imaging to be able to understand what's changing, to be able to detect change on a smaller level. We'll have a better assessment of genetic risk for who's going to go on to develop the more advanced forms, and again, try to tailor care toward those patients. And then finally, a question that always comes up is stem cells. And this is something that is currently not available for the advanced form of AMD, but it is exactly the kind of treatment that makes sense. Because the pigment and the vision cells are missing, the idea of putting in a stem cell to try to allow the retina to still function, to patch it, if you will, is clearly promising and is something that there will be ongoing research for into the future. So I want to thank you all for being here. This is just an overview of the imaging, some of the patient experience, and the things that I'm looking forward to as a retina specialist. And thanks again for coming. And I now want to introduce Dr. Chris Flaxel, who's already been introduced, but we'll both be available for questions after this and then later as well. So thank you.
I want to thank everybody for coming. I'm Chris Flaxel. I'm a professor at Casey Eye Institute and the director of the Macular Degeneration Center. And looks like we have a great group of people. And thanks, Becky and Steve, for making the trip, with Georgie down there too, I think. I'm going to discuss some of the clinical trials for macular degeneration. And Brandon's given a great overview of macular degeneration. So I'll touch on a couple other things and then discuss some of the trials that are either ongoing or completed or what we're looking forward to. So as a background, I just wanted to also say, on top of what Brandon has said, that the prevalence of macular degeneration does vary with ethnicity. So there are some populations that are at higher risk of macular degeneration. So Caucasians and Asian populations have a higher risk than do Hispanic and African populations. And Brandon touched on this too. There is a genetic component, but the disease is multifactorial. That means many things play into it. Environment, dietary, medical, and lifestyle factors all have influence. And again, don't start smoking or stop if you smoke. That's a really, really bad thing in macular degeneration and for your health overall. So again, cigarette smoking is the main modifiable risk factor that we have. Levels of antioxidants also do seem to play a role, and we don't recommend things like high-dose vitamin E above the doses that are in the AREDS vitamins. We also say Mediterranean diet, so lots of green leafy vegetables, and there actually is some evidence that caffeine may be protective in macular degeneration. People are always asking me about aspirin as well, and because there have been varying reports about the use of aspirin, a lot of people in the macular degeneration age group are on aspirin daily or every other day. And in very large studies of over 100,000 patients, aspirin was not associated with an increased risk of macular degeneration. So we generally say if aspirin has been prescribed, keep taking it. Again, genetic factors, this is a polygenic condition. That means there's multiple genes that probably play into this. The risk of developing the disease, however, is 3 times higher in people who have a family member with macular degeneration than those who don't have a first-degree relative with the disease. And there is this pathway called the complement factor pathway. And one of the drugs that we've been using in clinical trials works along this pathway, so I'll touch on that a little bit again later. The genetic variants discovered to date explain about half of the classical sibling risk of macular degeneration. So we know that siblings have an increased risk. About half of those cases can be attributed to a genetic risk. And commercial genetic testing is available in some cases. However, at this time, we don't feel that genetic testing will alter our clinical management. It's another question I get a lot. Should I have my genes tested? We don't recommend routine genetic testing for macular degeneration. And on to some clinical trials now. So I wanted to just show people over the last few years, give you an idea of how many clinical trials over the whole world are going on for macular degeneration. This is from the worldwide AMD clinical trials in 2014. The red areas are where the most trials are done. So that's the United States and Europe. Very few in other countries. This is now in 2017. The other countries are coming up, but you can see the numbers in the United States went from around a few hundred to over 600, and the numbers in Europe went from 70 to over 300. So the number of clinical trials, and in even other countries, even in China, it's about quadrupled there. So the clinical trials are going on all over the world, and because there's an increased risk in some populations, the companies, and I'll talk about this too, actually want the drugs to be tested worldwide. Our current treatment, as those of you know who have macular degeneration, involves basically taking the vitamins, injecting drugs into the eye, and lifestyle modifications. And the 3 drugs that we have now, which have all been well established, are bevacizumab, ranibizumab, and aflibercept. Studies have been done not comparing these 3 drugs, but comparing two drugs to one of the other, or 2 drugs together and one to the other. So we feel these drugs are probably fairly equivalent. However, different people can respond differently to the drugs. So often you'll start with something, switch to something else if it's not working, sometimes have to go back to the first one. But you can use different drugs in different settings. Sometimes people respond to one better than another. Sometimes they don't respond to one, but you can go between the drugs. As most of you know, there's a cost difference between these. So the one that's considered kind of the generic or off-label would be bevacizumab. It can cost around $200 an injection. The other two, which are drugs that are approved by the FDA for this treatment and were developed for the treatment, cost about $2,000 an injection. So it's a fairly large difference in the cost. And if you're getting injections in both eyes, it's going to be double that. So this is our treatment goals for macular degeneration are basically to improve the outcomes. So as Dr. Lujan talked about, our goal is to take you from wet basically back to dry. So it's not a cure, it's a treatment to go back on the pathway of the dry. We'd also like to decrease the number of visits. A lot of times we're doing these injections on a monthly basis. I have patients who have been in clinical trials, and when this first started 12 years ago with me, they're still getting shots, and they're getting these shots every month. So it's a lot of visits, it's a lot of time coming in, it's a lot of commitment from the family. We'd like to decrease that if we could. We'd like to increase access. There are still people who have trouble getting in to get treated. People who live in rural areas have a hard time getting the treatment. And we'd really like to decrease the cost so all the drugs are costing about the same. I'm going to talk a little bit about some of the studies that we're doing for dry macular degeneration. So if you look at it, we have treatment for wet. Our goal with the wet is to take you back to dry, but we don't have any treatment right now for dry except for the AREDS vitamins. So this was a study that is ongoing right now, and we're doing it at Casey, is looking at an antibody that is designed for the treatment for geographic atrophy. It binds to this complement factor D. It is an injection into the eye. The initial phase 2 study did show potential benefit. That study was called Mahalo, and this is just the study design here, and it did show a 44% reduction in the geographic atrophy area of progression. And it was actually seemed to work better in patients with a certain genetic variant. So from this study, we went to a phase 3 study. Actually, this was 2 studies. The Spectra study is being done in the United States. The Chroma study is being done in Europe. And they were parallel studies, so that means they were exactly the same in 2 different countries. Over 1,800 participants, 20 countries. Unfortunately, the Spectra study, which we've just looked at the 1-year data, did not meet the primary efficacy endpoint. That means it really didn't work. So the safety profile was good, but we did not see any benefit in slowing the rate of progression. So at this time, we're waiting for the results from the European portion of the study, but the injections are being withheld at this stage. So that was very disappointing. So the next study that is also ongoing is looking at a pellet that contains the drug brimonidine. This is also injected into the eye. But when we can put a drug into a pellet form, it's going to be a slower release. So that means we won't have to give it as often. And this is what we call an alpha-2 receptor adrenergic agonist. Basically, it's going to help some other things and may be protective against degeneration or deterioration of the cells. So it may protect the cells. This study is still going on. The initial portion of the study did show some benefit, and the injection is done about every 3 months. So that's ongoing. There's no data on that one at this time. We're still following those patients. A new study that we've just started at Casey is looking at a drug, which some of you may know because it's a drug that's currently available and used for diabetes. So it's a medication you take by mouth. It's called Metformin. And it may be effective in slowing the progression of geographic atrophy. It's because it kind of slows metabolism, so it may help slow down the turnover of those cells. And in this study, we're randomly assigning patients on a 1-to-1 basis to either getting the drug or not getting the drug. And they'll just be followed to see how their geographic atrophy progresses. I'm going to switch a little bit to some trials for the wet macular degeneration. So right now we do those injections on a regular basis. Some patients need them every 4 weeks, some need them every 6, some may need them every 2 months, but everybody needs ongoing injections basically for the rest of their lives. The latter study is looking at an implantable device that's refillable. So this device is a small device that we surgically implant into the outside of the eye, that goes into the eye, and then it allows us to inject the medication into this device. The device is then slowly released into the eye. And you don't see it from the outside. It's very, very small. And this study is ongoing as well right now. So we're not recruiting any further patients, but the patients in the study are being followed. So we may not need to refill these once every 6 months, which would be so much better than an injection every 4 weeks. People are always asking about stem cell therapy as well. Right now, as Dr. Lujan said, there is no stem cell therapy available in the United States. You'll see things about stem cells used in China and other countries. Unfortunately, we don't know what their regulations on these cells are. So I usually tell people I probably would not go to China and ask for stem cell therapy, or to India, just because you don't know where those cells came from. But I think it is important, especially in what Dr. Lujan talked about, what's called the PSC-derived RPE. That's where you implant this retinal pigment epithelial cells into the subretinal space. I think that's going to be very important, and that's ongoing studies right now with that. Gene therapy, we've also done some work with that. This is some data on a study that currently is no longer recruiting, but that is in follow-up. And this does support the role of ocular gene therapy as a potential approach in long-term treatment of macular degeneration. Again, it's still ongoing. It does require a surgical procedure to do this therapy, and we're still following those patients. And then this brings us to the gene therapy that's recently been recommended for approval by the FDA for Leber's congenital amaurosis, or LCA. LCA is a rare hereditary form of retinal degeneration, so similar to what Becky has, but something that comes on either at birth or very, very early, where these children are basically blind by the time they are 1 to 3 years old. It affects about 1 in 40,000 newborns. There's 18 types of Leber's congenital amaurosis, so 18 different genetic variants for this. So there's a lot of different possibilities of finding the right gene for this, but the drug Luxturna treats the mutation caused by the mutations in the RPE65 gene. This is a drug that was developed by a company called Spark Therapeutics, and it's a genetically engineered virus to correct the defect in 2 defective genes in the RPE65. And these code for an enzyme that nourishes the retina. So what they learned from all this, first of all, is that gene therapy is way more complicated than they initially thought it would be, and that genes sometimes don't go to where you think they're going to go, so they have to be put where you want them, and then you hope they're going to stay there. And getting them to that spot in an eye is difficult. They have to be injected under the retina. The retina is already damaged by all of the degenerative process there. There also is some risk when we're injecting these cells that there could be death from this. Nobody really knows that, but there's always a risk of cancer developing. Nobody knows that in the long term either. However, in the LCA study, 11 of the 21 patients experienced a significant improvement in vision without serious side effects. So that's very, very beneficial. These kids were blind, and now they can see. So it is injected under the retina, and it does seem to prevent further progression. So it has been, FDA panel has recommended approval of the treatment and the drug. It would be the first gene therapy in the eye. The cost, they have no idea right now what the cost would be, but they're thinking it could be $1 million to treat both eyes, which is a lot of money, and nobody's real sure who's going to pay for that either. It is only one treatment, but it would benefit about 6,000 very young people globally. So these are people who might be able to see to go on to have lives and careers with vision. There's a lot of other drugs that we're looking at that may have some benefit for macular degeneration as well. A very common drug is a tetracycline drug. And this drug may have neuroprotective properties. So there's several ongoing trials looking at this very common antibiotic to see if it protects against retinal degeneration, again, in geographic atrophy. There is another study that we're doing at Casey, and this is looking at a drug called Arpan. And the drug itself is called abicipar. So this is a small molecule that is kind of engineered to bind to some target proteins. And it binds to some of to VEGF, which is a drug that allows blood vessels to grow. So this drug is then injected. It has a longer half-life in the eye than the drugs we use right now. So it's injected along with the drugs that we're currently using to see if it helps them to extend the length of time between injections. And that study is ongoing right now at Casey as well. And it's called the Sequoias Study. There's several other studies looking at different drugs with different names like Hawk and Harrier. These are other kinds of drugs that may extend the time between injections again. Squall Amine is another drug that's in an eye drop form that also may be a beneficial drug looking to basically extend the time between the injections. So anything that could help the drugs work better or give you more time that you don't need a shot for, say, 3 months or 4 months or 6 months would be very helpful. Again, that's another ongoing study looking at this in an eye drop form. There's oral drugs as well. This is a tyrosine kinase inhibitor. It's another drug that can slow down these blood vessel growths. However, whenever we're giving oral drugs, there's a pretty high risk of systemic or other side effects. So I've kind of found that doing oral drugs is not the best way to administer this because the generation that needs these drugs is on a lot of other medications. There's a lot of potential for other side effects. So I think either directly into the eye or a drop form is probably the better way to go. There's also a lot of work on things like radiation, and there's a current study that's again looking at doing stereotactic radiotherapy to help slow down the rate of progression along with injections. And that's ongoing and should be completed in 2019. Another interesting thing is, some of you may even be on these drugs. Levodopa and carbidopa are both drugs that are used for Parkinson's disease. And when Dr. Lujan was talking about big data or large databases, somebody happened to look at 3 large patient databases and found out that patients who are on these medications really didn't have any diagnosis of macular degeneration until they were well into their 70s. So they're kind of looking at to see if these being on these drugs could prevent you from developing macular degeneration. And that's something that's being evaluated now. There's another study that we're currently doing that we're just getting ready to start at Casey called the Athiya Study, looking at a drug called OPT-302, again in combination with the standard of care, right now in combination with ranibizumab. It's a recombinant fusion protein, so another drug that binds to different growth factors, again in the eye, that may again extend the time between injections. There's a lot of studies that have had negative results, and most of them are in dry macular degeneration, but the FOVISTA study was looking at a platelet-derived growth factor in wet macular degeneration. That phase 3 study showed no benefit. Another study, again looking at PDGF, which is another growth factor, showed no benefit. Many drugs for dry macular degeneration, in fact, all the drugs right now have shown no benefit in that. So for dry, we still only have the AREDS2 vitamins and a couple other clinical trials that may help us in that area. And I want to thank everybody for coming.